So if you're surprised to hear my voice on giving this presentation on failure to thrive, I don't blame you. I know a lot about nutrition, I just don't really practice it. In this presentation, we're going to talk about failure to thrive, both from children and from an adult's point of view. But before we can talk about what it means to not thrive, I need to teach you about nutritional support and stress as well as starvation and what this means. Who better to do this than a general surgeon who has to daily remove patients' intestines and feed them, or not, depending on their body weights and their BMI. In this presentation, you will learn everything that you need to know about nutrition before you walk onto the floor as a third-year medical student. Then you'll hone your skills. But this is the baseline information that you need. Let's get started. First, let me say that you're going to need a calculator for this presentation. And I'll tell you up front what formulas I expect you to know and memorize and others that you can look up on your own. But let's take a look first at the learning objectives. And as we go through this presentation, you'll understand better what it means to be malnourished or to be starved or both. So let's start. First, we need to define failure to thrive. And then we need to talk about what is enteral nutrition, what is elemental nutrition, and what is parenteral nutrition. Then we need to talk about how starvation differs from malnutrition and several conditions that preclude the use of enteral nutrition. In other words, who can we feed and who can't we feed? What is the basal metabolic rate or the resting metabolic rate, and how is it calculated? What's the importance of phosphate in phospholipids? And explain why a person who's obese can actually be malnourished, or a person that's obese can actually be starving, and vice versa. We'll talk about all of this in this presentation, but we have a few more learning objectives to discuss first. I'm not a biochemist and I don't pretend to be, but we're going to go through some basic biochemistry. We're going to talk about the actual biochemistry that you need to take care of a patient. Not all of those enzymes are important. We need to learn what makes an essential amino acid essential, especially in humans, because different animals have different needs for their amino acids. What is dextrose and how is it different than glucose, or are they the same? What is indirect calorimetry, or commonly known as a metabolic cart? And how is it used in nutritional assessment? What is a metabolic equivalent, commonly known as a MET? And give an example of how that's used in the calculation of metabolic stress. What is a PEG tube, a percutaneous endoscopic gastrostomy tube? And how does that differ from a jejunostomy tube? And why would you use one over the other? This isn't meant to be a surgical presentation, but I find the easiest way to learn about nutrition is to take it from the very simple mathematical view of what happens if you have a patient who doesn't have any intestines and can't eat, and you as the physician are solely responsible for feeding this patient. Once you understand the mathematics involved, you can feed anybody, orally, intravenously, or otherwise. Let's get started. And you know I'm big on names, but this one you should know from organic chemistry. Who is Johann Geldahl? And what is the ideal ratio of non-protein calories to grams of nitrogen? And while we're on this, what is non-protein calories? And how do we come up with this figure? Why is it important? And how will it help you to feed a patient who's in heart failure or has fluid overload, or the opposite, is in kidney failure, or perhaps has cirrhosis and is in liver failure? How are we going to assess failure to thrive in any patient, and then turn that around and talk about how they're starving and what their stress level is? Believe me, you'll see lots of patients who come into the emergency room who haven't eaten in days because they're vomiting or they're sick or they have nausea or they've just finished chemotherapy. Starvation is very common, and it's not just in Africa. Okay, let me be very blunt about this one. You need to read this chapter, and I've attached it to this presentation. This is required reading. This isn't optional, and any questions can be taken directly from this reading, whether I cover it in the presentation or not. So you need to read this chapter and use it in conjunction with the information that I give you in this presentation. And to help highlight those important points to help you understand nutrition better, I put a quiz at the end of this presentation. I mean it. At the end of this presentation, you should be able to assess the nutrition of anybody. You should be able to walk into a grocery store, pick up a food, look at the label, and see whether or not it's being sold appropriately and labeled appropriately, and whether it's healthy or whether it's organic or whether a high-protein diet is good for you or not. Read this chapter from the American College of Surgeons textbook, Surgery, Principles and Practice, called Nutritional Support, Chapter 22. In conjunction with this presentation, you'll be ready to hit the wards when you're a third-year student. Okay, let's take a minute to look at the scheme. Failure to thrive. What does that mean? Well, there are actually patients that have an adequate caloric intake, but for some reason, they just can't maintain their weight. They lose muscle mass. They're weak. And then there are those who simply don't eat and have an inadequate caloric intake. We can help those patients. We can feed them sometimes. But if we understand what failure to thrive is and some of the causes, perhaps we can better assess our patients' caloric intakes and their caloric needs. But before we assess failure to thrive, we got to figure out how many calories do you need to just maintain your basal metabolic ratio, or resting metabolic rate, or basal metabolic rate. It's all the same. So what I was just saying, and you're going to need your calculator, we need to calculate first what the adequate caloric intake is for somebody based on their age, their height, their initial weight, their BMI, and we already learned that the BMI is not 100% accurate. You can have someone whose BMI is 40 and they can look like Arnold Schwarzenegger. And then you can have somebody like me whose BMI is 40 and I don't look like Arnold Schwarzenegger. So you need to use all of these numbers in light of your clinical presentation of the patient. What do they look like? What's the history tell you? What's their physical exam tell you? And believe it or not, some of those things they use at the gym, like calipers, to measure your percentage of body fat are grossly inadequate and inaccurate. There are better and other ways to measure this. We'll take a look at some of those in this presentation. Let's get started and take a patient who needs us to calculate their adequate caloric intake. I'm a real stickler for being very hard on the dietitians at my hospital. In fact, while I was on staff at the various hospitals, I always was on the nutritional committees and the enteral and parenteral nutrition committees. I worked closely with the pharmacist to generate total parenteral nutritions and enteral nutrition mixtures for my patients. There is nobody in the hospital who knows more about nutrition, believe it or not, than the doctors, especially the surgeons. And after this presentation, you're going to understand why that is. But when you get into the hospital, make sure that you always include the registered dietitians in your daily rounds. Read their notes. Some of the dietitians can be your best friends. They will write these nutrition orders for you. They will call you when the patient is metabolically compromised, and you can teach them as much as they can teach you. The registered dietitians at your hospital are indeed your best friends. Here's an example of why we are the best at nutrition. Back in October of 2009, a couple of years ago, I was called to evaluate a patient in the emergency room who was working that day as a substitute teacher at one of the local junior high schools. Judy Gustafson presented to the hospital and had a small bowel volvulus. I don't know why this happened. She'd never had surgery before, but her intestines had completely infarcted and I had to remove all of her small intestine. What's she going to eat? How is she going to get her nutrition? Eventually, I referred her to the University of Arizona, where she became the first small bowel transplant in the state. But before she made it down there, guess who was in charge of making sure that she was nutritionally balanced and ready for that operation. It was me. It wasn't the registered dietitian. It wasn't her family physician. It was the surgeon, the guy that removed all of her guts. So the best way to learn nutrition is to pretend that you're looking at Judy. And we'll take a similar patient. We're going to remove his intestines, and then we're going to talk about how to figure out how much nutrition he needs, what nutrition he needs, and how to give it to him. Let's start. Turn on your calculators. But so far, I've already used some words that you probably don't know what they mean. So let me define them, and as we go through, this will make more sense. So now that you're completely responsible for your patient's nutrition, let's learn how to give artificial nutrition. Total intravenous nutrition, called TPN for short, total parenteral nutrition. Once you learn how to completely feed somebody who can't be fed, you can feed anybody. You will be able to read the labels at any grocery store and know exactly what somebody's caloric needs are and whether the food you're eating is too much or not enough, or too much in fats or too high in proteins, or whether it can damage kidneys or their liver. So let's take a look at some patients who simply can't be fed, and this was one of the learning objectives. Who are people that cannot be fed enterally? Enterally, of course, means by mouth, using their intestines. Well, sometimes we operate on patients and we can't feed them right away. Patients who have removed pieces of their small bowel or their colon. Multiple studies have been done that attempt to show that a patient can be fed immediately after surgery. I will tell you that many of those studies are flawed. A lot of doctors like to admit that they send their patients home on postoperative day 3 from their colon resection, but these doctors never tell you that their patient was readmitted 3 days later with a big, bloated, distended abdomen, and the patients are puking because they were sent home too soon. The intestines are no different than any other part of the body. If you cut them, you're cutting through not only the tissue, but the innervation to the small bowel. And when you disrupt the autonomic nervous system that controls the peristalsis to the small bowel, it has to heal. It's no different than the injury to my own hand. Those nerves have to heal. And before those nerves heal, the intestines don't really pump food through very well. That's called an ileus. And a lot of patients develop ileus. An ileus can be caused from surgery or infection. Sometimes a patient comes in with pneumonia with a high fever and they've been vomiting. They have an ileus. Or if you get the stomach flu, that's an ileus. Your intestines are just sick. If someone's on a ventilator, sometimes you can't feed these patients orally, so we have to put a tube into their stomach, through their nose, down into their stomach. That's called a nasogastric tube. What about patients who've lost their intestines from congenital atresias or volvuli or postoperative surgery or from trauma? What if they're recovering from a stroke and they can't chew? What if they have cancer of the esophagus or cancer of the palate or perhaps even cancer of the tonsils and they can't swallow because it hurts? These patients might be having failure to thrive. They can't eat enough and the cancer is causing hypermetabolism and they're eventually losing more and more weight. Some patients recover from their eating disorder and have refeeding syndrome. Women who are anorexic or bulimic, believe it or not, just can't pick up a Big Mac and eat it. They actually develop symptoms of a refeeding syndrome. That's not applicable to this talk, but again, this is a patient who might need intravenous nutrition. What about those who have severe infections of the airway? For example, children with epiglottitis. How are you going to feed this child? And those children with congenital anomalies. If we're talking about failure to thrive as an infant, what if your patient has a congenital fistula between the trachea and the esophagus, or the duodenum hasn't developed, or the jejunum does not have a lumen called jejunal atresia, or they have pyloric stenosis and they're vomiting, that typical hyperperistaltic emesis that they have, or a child who has a midgut volvulus and loses most of his intestines. These are all patients that you can't feed. So if we know how to feed these patients, we can feed anybody. So how exactly are we going to figure out how many calories that you need? As we go through this presentation, it might be easier to figure out these numbers on yourself. Once you understand the number of calories that you need on a daily basis, you'll be able to tune your workout at the gym or lose weight very slowly, as you should, and recommend weight loss to your patients. Never walk into the exam room and tell your patient, "You're fat, you need to lose weight." Because if you say that, you'll never see that patient again. Fat people know they're fat. And believe it or not, skinny people also know they're pretty skinny too. Let's take a look at how to calculate the basal metabolic rate. The rate of lying still, sitting, breathing, not doing anything. In fact, sleeping is considered a little less than the basal metabolic rate. It's given a MET, M-E-T, a MET of 0.9. We'll talk about METs in a second. What you do need to memorize is this first number. Estimate of a daily BMR, the basal metabolic rate of a human being, just lying in bed, flat, breathing, is about 25 kcals per kilogram per day. You need to memorize this. The mathematical way is called the Harris-Benedict formula, and you don't need to memorize this, but you do need to know it exists, and dietitians will use it on your patients in the hospital. The Harris-Benedict formula calculates for a male or female, depending on gender and depending on their weight, height, and age, the amount of calories they need. Believe it or not, all of this also works for infants too, and babies. Pretty good estimates of the calories that people need, whether they're an adult, a teen, a child, or an infant. 25 kcals per kilogram per day, and the Harris-Benedict formulas. You're going to see these throughout your career. So the Harris-Benedict formula, and I won't reiterate them here, will be needed to calculate our upcoming patient. And notice on males, it's the number 66 plus 13.7 times the weight. And then you look on females, it's 665 plus 9.6 times the weight, etc., etc. That's not a typo. For males, it's 66. For females, it's 665. It's just the way the mathematics works out. This is a tried and true formula that's been around for years. Okay, here's Anthony. Anthony weighs about 180 pounds, and if you do the math, it's about 82 kilograms. He's 5 feet 10 inches tall and 164 centimeters in size, and he's 51 years old. The Harris-Benedict equation says that he should have about 1,650 kcals per day just to lay in bed with his eyes closed, breathing. But if you use 25 kcals per day, you see it's about 2,045. So what's the right answer? This stuff is not an exact science. So what I've done is calculate both, and let's take the average. So averaging the Harris-Benedict and the unstressed 25 kcals per kilogram per day means that Tony needs about 1,850 kcals per day to just survive, to sit in a chair and do nothing. Let's use this as his BMR. Now let's make it a little tougher. Instead of using my patient Judy Gustafson, let's talk about Anthony and assume that Anthony has no intestines either. But you got to feed him, or otherwise he's just going to die. So how are we going to figure out what he needs in terms of his protein requirements, his carbohydrate requirements, and his fats? Because in reality, everything you eat is made up of protein, carbohydrates, or fats. And we know that lots of carbohydrates together make sugars, fats come in fatty acids, and proteins come from amino acids. So basically, we need to know protein, sugar, fat requirements, his essential fatty acids, the essential amino acids, and then we're going to throw in some vitamins and minerals. You're going to learn that most everything that you see on television telling you to take vitamin and mineral supplements, at least in America, is a waste of your money. You simply cannot push the stoichiometric equation to the right by giving somebody more vitamins and minerals than what their body can use. Just because you give it doesn't mean it's stored and doesn't mean it's used. Recommending a daily multivitamin to most of your patients is a waste of time. However, if they've had bariatric surgery, that is weight loss surgery, or they've had intestinal surgery and they've lost part of their jejunum where they can't absorb vitamin B12, they might need a multivitamin. Again, you got to do a history and a physical exam and figure out what kind of surgery a patient's had. If a patient shows up in the emergency room and they got a cut on their belly and they say, "Doc, I had surgery and they took some of my intestines out," you better find out what part of the intestine and how much, because they might be suffering from malnutrition. Notice, not starvation, malnutrition. That's the difference. A shortage of amino acids, electrolytes, vitamins and minerals, that can be malnutrition, not starvation. Here's what intravenous fat emulsion looks like in a hospital. Most pharmacists will make the fat emulsions from a 20% mixture called intralipids, and these intralipids contain phosphates. They are, in essence, phospholipids. You need to memorize this number. Fats provide about 9 kcals per gram. Memorize this. The next time you go to the store and you pick up some peanut butter, look at how many of the calories are provided by fat, and then divide that by 9, and that'll tell you how many grams of fat are in each serving. So we have to figure out how much fat Tony needs. In the usual American diet, between 30 and 40% of your calories should come from fats, because these intralipid fat emulsions and the fats that you eat from food in the store usually contain the essential fatty acids that you need. We'll talk about this in a minute. So why do we need that amount of fat in our diet? Well, first of all, you remember these inflammatory mediators, the prostaglandins, leukotrienes, and thromboxanes? These are all made from essential fatty acids, arachidonic acids. Medium-chain triglycerides, 6 to 11 carbon atoms, are the usual source of fats that the human can use. Linolenic acid and alpha-linolenic acid, as well as linoleic acid, are considered the essential fatty acids. So, if we can supply our body with linolenic acid, linoleic acid, and alpha-linolenic acid, we can manufacture most of the fats that our body needs to make these inflammatory mediators. Okay, here's another number that you need to memorize. Protein provides 4 kcals per gram. Put this in your memory bank for all eternity. The pharmacist in a hospital will be able to supply a patient with their essential amino acids by using this mixture, and it usually comes from a bottle of 15% amino acids. That means 15 grams of amino acids per every 100 cc's. So one bottle gives us 600 kcals. The number you need to memorize is protein, 4 kcals per gram. I'm not going to ask you to memorize the essential amino acids, but we're going to talk about some of the important ones. Here they are, and you can look at the list. Arginine, histidine, isoleucine, leucine, lysine, methionine, phenylalanine, threonine, tryptophan, and valine. And here's the basic structure of an amino acid. This is the structure that they all have in common. But we have to make sure that our patient, Tony, who doesn't have any intestines, is going to get his essential amino acids. Once he has these essential amino acids, he can then make the proper proteins to keep his oncotic intravascular pressure up. Let's keep going and take a look at how we're going to calculate this. So we know that fat provides 9 kcals per gram, protein is 4 kcals per gram, and carbohydrates, or glucose, gives us 3.4 kcals per gram. You need to memorize this too. In the hospital, the pharmacist will make up the total parenteral nutrition admixture by using a solution of 70% dextrose and water. What's the difference between dextrose and glucose? Well, simply glucose is L-glucose, levorotatory glucose, and dextrose is D-glucose, or dextrorotatory glucose. These terms are confusing, but L-glucose is hard to find in nature. We'll talk about this in a second. But you need to remember 70% solution is what most hospital pharmacies use to make up their TPN solution. Remember, 3.4 kcals per gram. So far, I've asked you to memorize 4 numbers. 25 kcals per kilogram per day as the amount of basal metabolic energy. Carbohydrates, 3.4 kcals per gram. Proteins, 4 kcals per gram. And fats, 9 kcals per gram. Once these are in your memory banks, the rest of it gets easy. So once we've asked the pharmacist to mix up Tony's total parenteral nutrition admixture, we need to make sure that in spite of just looking at numbers, that everything actually fits into the solution, that we've also given him not just the right amount of calories, but he needs volume, he needs intravenous fluids too. And then once we've looked at this mixture, we're going to have to add vitamins and minerals to it. So if we know the non-protein calories, and this makes sense, non-protein calories are the carbohydrate calories and the fat calories, divided by the grams of nitrogen, and that's calculated by the grams of amino acid divided by 6.25, and this is just an approximation, that this ratio of non-protein calories to grams of nitrogen should ideally, in a perfect patient who's healthy, who has no liver or lung disease, should be about 150 to 1. We can play around with this number if a patient has kidney failure or if they retain CO2. If a patient has severe emphysema and severe lung disease and they retain carbon dioxide, well, think about this. If carbohydrates are broken down into CO2 and water, the last thing we want to do is to give somebody with COPD who retains carbon dioxide another source to make too much carbon dioxide. If we give them too many carbohydrates, not only can we overfeed them, but we can make their emphysema and their COPD worse. All this makes sense? I hope it does, because it's all tied in on how we're going to feed Tony. So back to what I was saying about what's the difference between glucose and dextrose. D-glucose is most common, L-glucose is exceedingly rare, and we can't use it. There's stereoisomers and enantiomers. So don't get all of this confusing. We're not going to get lost in the details. All you need to know is that you can't really find levorotatory glucose anyway. Almost everything in nature is dextrose or D-glucose. That's what you're going to use in the hospital. Now, we're going to talk about fluid boluses here in just a minute. The ideal solution to give a fluid bolus to a patient in the hospital is normal saline solution. Doesn't have any dextrose in it. And a fluid that surgeons like to use is lactated ringers. All of this is beyond the scope of this talk. I have to leave something for your third and fourth years for you to learn. For now, we're just going to concentrate on nutrition, and that's dextrose. And fluids, and that's probably going to be saline or even sterile water. Hold on. This will make sense in a second. Okay, so back to Tony. Let's start to feed him. Remember, he has no guts. We have to give him his basal metabolic needs of 1,850 calories a day. And remember, this is his minimum intake. But what if he's stressed? What if Tony's in the hospital, has no guts, but he's sick and has pneumonia? Should we add more calories to account for that? What if he's actually up walking around? What if Tony's one of those lucky individuals like Judy who lost her intestines and is able to go to the grocery store and go visit her neighbors and do the normal daily activities? Should we give Tony more if he's active? Sure, we will. But we also have to figure out not only his caloric intake, but his fluids. Let's get going. Keep your calculator warmed up. Here's another number you probably should memorize. The daily protein needs for a normal adult and child, remember these are based on body weight, so they are applicable to children too, is about 0.8 grams of protein per kilogram per day. So Tony needs about 65 grams of protein a day. Multiplied by 4 kcals per gram, he's going to need about 260 kcals a day from his protein. We also know that 30 to 40% of his total calories should be from fat, because that's what it is if he's eating orally, but he's not. So we need to reserve 30 to 40% of his total calories as fat. So 30% of 1,850 is about 555 kcals as fat. Divided by 9 kcals per gram, because that's what fat gives us, means that we're going to have to give him 62 grams of fat a day, 65 grams of protein a day, and then what's left over is going to be in terms of his dextrose, or 1,035 kcals, or 305 grams of dextrose. So we're going to need to tell the pharmacist all of this to mix up how we're going to feed Tony. 260 kcals a day of protein, 555 kcals of fat, and 1,035 from sugar. Remember, Tony depends on us for his entire nutrition, and believe it or not, there was a day when we couldn't do this. Nutritional chemistry has advanced to the point where we can feed people intravenously for years. This is amazing. And nutritional research is one of the most impressive areas of chemical research. All Tony needs is carbs, lipids, proteins, vitamins and minerals, and maybe even some other special ingredients, and we'll talk about those too. So here's a summary of what Tony needs. Let's ask the pharmacist to mix this up. Now, I'll tell you that today the pharmacist has a machine and he just punches these numbers in. But let's assume that you're out in the middle of nowhere and your hospital can't afford one of these machines, and you have to figure this up. So Tony needs 65 grams of protein a day, and we're making it from that 15% solution. So if you do the math and do this until you understand where it comes from, I'm not going to be your math teacher, 65 grams of protein a day will give us 433 cc's from this vial that we need. So the pharmacist will hang this large bottle and he'll steal from it 433 cc's. Why do you need protein? To build muscle, to build other proteins, and to keep your oncotic pressure. Arnold and Franco Columbu and even Lou Ferrigno need a lot of protein. These guys can eat or drink so much protein that they can actually harm their kidneys. Another talk for another day. So why do you need fatty acids? It turns out that intralipids are a source of phospholipids, and you need phosphates to make ATP. It turns out that fatty acids are the heart's main source of fuel, not glucose and not proteins. It turns out fatty acids are the main source of fuel for the heart. Intralipids, which contain phospholipids, are used to make cell membranes. You've seen this picture on the right before of the lipid bilayer. Without fatty acids, your cells don't have membranes and your heart can't pump. So back to Tony. He needs 62 grams of fat a day, or from this vial of 20 grams of fat for every 100 cc's, Tony's going to need 310 cc's from this vial. So why do you need glucose? Well, you have a brain, and your brain burns glucose. Glucose is virtually the sole fuel for the human brain, except during prolonged starvation. And then what do you burn during starvation? I'll give you a hint. That's the basis of the Atkins diet. The Atkins diet is basically a starvation diet. It uses protein. The only time the body actually burns protein and breaks it down is during prolonged starvation. One of the byproducts of starvation is ketones, and you pee those out. When your patient comes to the emergency room and they've been vomiting and they have ketones in their urine, they're either diabetic or they're starving and they haven't eaten. So we need to treat ketones in the urine as starvation. But back to Tony. Glucose is the virtual sole fuel for the human brain. Tony needs 305 grams of carbs every day, and the pharmacist is going to take this 70 grams per 100 cc solution, and he's going to give Tony 436 cc's of this solution. And he's going to mix it all into a big bag, and we're going to add vitamins and minerals, and we're going to feed Tony in the vein. So when we add all this together, we're giving him dextrose to feed his brain, we're giving him phospholipids to feed his heart, and we're giving him protein to feed muscle, to build muscle, and, of course, to allow him to make albumin to maintain his oncotic pressure. He needs a total of 1,179 cc's of solution a day. So now the calories are there, and there's even some fluid and water in there. But now we need to go back and figure out how much water Tony needs too. There's a formula for this. Hold on and write down this 1179 cc's because we're going to have to add some water to it to hydrate him. Okay, this applies for babies, children, teenagers, and old people. You need to memorize this that's in red. Here's the formulas that we need to calculate how much fluid a patient needs. Here's the way we calculate it. 100 cc's per kilogram for the first 10 kilograms of a patient's body weight. Added to that is 50 cc's per kilogram for the next 10 kilograms, and then 20 cc's per kilogram for the remaining. If we're going to give a fluid bolus, and you need to memorize this, a fluid bolus is usually calculated at 20 cc's per kilogram of body weight. Why would you ever need to give somebody a fluid bolus? Well, we live in Phoenix. You go hiking, your lips are dry, you're not urinating, you haven't eaten all day, you have ketones in your urine, you're thirsty, you grab a bottle of Gatorade and you drink a bottle of Gatorade. How much Gatorade did you drink? Well, figure it up. 20 cc's per kilogram, that's the amount of Gatorade that you should give yourself as a first slug if you're dehydrated. Applies to children as well as adults. So Tony weighs 81.8 kilograms. He's going to need, for this entire day, 2,700 cc's of fluid. Or, if we just hang an IV, he's going to need an IV at 114 cc's an hour. But we already have given him some of this fluid as part of his nutrition. Total, he needs 2,700 cc's a day. Remember that number. So now we're faced with having to calculate how much free water we're going to give Tony in his nutrition. Don't forget that in addition to nutrients, people need fluid and water. And because he has no intestines, we're going to have to provide that for him too. So his total fluid requirements per day is about 2,700 cc's, of which he's going to get 1,180 of those from his TPN. So in order to bring it up, we're going to have to add 1,157 cc's of water to his TPN, and then run that over 24 hours, assuming that he is not losing water any other way. For example, does he have a fever? If he does, he's going to sweat, and he'll need more fluid. Is he active? If he's active, he will evaporate more water. Is he on a ventilator, where he'll lose water every time he exhales? We have to take all of these losses into account when we calculate his water needs. Does he have diarrhea? If so, we'll have to add those fluid losses into the amount of water that we give him daily. But let's not make it complicated. Just at a minimum, he's going to need 2,736 cc's of fluid a day, of which he's going to get 1,179 cc's from his nutrition, and the pharmacist is going to add another 1,157 cc's of fluid. His urine output needs to be at 0.5 cc to 1 cc per kilogram per hour. You need to memorize this because it holds for adults as well as it does for babies, children, and teenagers. 0.5 cc per 1 kilogram per hour. In adults, this comes out to about 30 cc's an hour plus or minus. And in residency, you're going to need to know that number. But if you know the patient's weight, you can always calculate what their hourly urine output should be. So why do we care about this urine output? Let's take a look. Urine output actually tells us a lot. It tells us the hydration of the patient and whether the kidneys are being perfused. Or what if the patient's not urinating? Then are they dehydrated? Are the kidneys being perfused? Is the catheter blocked? Or is one of the kidneys not functioning? What if they have diabetes and we check their urine and it's full of glucose? Or better yet, what if they come in and the urine is full of ketones? Are they starved or are they in diabetic ketoacidosis? If someone's starving, they've run out of glucose and are in ketoacidosis from the Krebs cycle, gluconeogenesis. If you remember all of this from biochemistry, now it's going to become clinically useful. You don't need to know any of those enzymes involved in the Krebs cycle, but what you do need to know is that an excess of ketones in the urine is a sign that the patient is not using glucose, just like a diabetic, or they don't have any glucose to use and they're generating glucose from lactic acid and or gluconeogenesis. Are they hydrated? Look at the specific gravity. If the specific gravity is normal, they're hydrated. If it's really high, they're dehydrated, and you need to fix that. So urine output is very important, not only to nutrition, but to the status of the patient overall. For the most part, if you eat a balanced diet, you'll get all of these recommended vitamins and minerals. The fat-soluble vitamins, vitamins A, D, E, and K, you'll also get from a normal, healthy diet. If you're on a blood thinner, for example, warfarin or Coumadin, we know that vitamin K reverses it. So if our patient Tony takes a blood thinner, and he doesn't, but if he did, we have to be careful about his vitamin K, which he'll get from eating leafy vegetables, lettuce, and salads. And you'll find patients who come in on a blood thinner, like Coumadin, who love salad, and you never can get a dose of vitamin K regulated properly. To prevent neural tube defects, a woman needs to take vitamin B6, folic acid. Vitamin B12 is important if you've had resection of your terminal ileum, because that's where vitamin B12 is absorbed. But vitamin B12 also needs intrinsic factor, which is made in the stomach. So if the stomach has been resected, the patient may not have enough vitamin B12, and they can have a megaloblastic anemia, a macrocytic anemia. Vitamin C is important to make collagen. Without it, you develop scurvy. You'll start bleeding from your gums and your lips. But again, most of this is available to us through a normal, healthy, regular diet. Most of us don't need to take supplements. However, Tony, our patient, has no intestines to absorb any of this. Luckily, we can give all of this to him as an intravenous form, and the pharmacist will mix that up. Again, most of these vitamins and minerals will be provided to Tony through his TPN solution and mixed in by the pharmacist. They come in very minute quantities. Interestingly, zinc is recommended to give at about 7 milligrams per day in a patient who's had massive burn injuries. Copper, manganese, chromium, and iron are generally considered trace mineral requirements. Every once in a while, it's important to give somebody an intravenous infusion of iron, but it's very rare. We've actually learned a lot about nutrition by operating on obese patients. Over the years, operations such as the vertical banded gastroplasty, jejunal ileal bypass, and other barbaric operations have been replaced. Now, today, we know much more about nutrition, and today's standard operation, the Roux-en-Y gastrojejunostomy, is considered the gold standard for bariatric surgery. But we've learned a lot from the vitamin and mineral deficiencies that these patients suffer from. The ones that you really need to know as a doctor are the following. The stomach produces a chemical called intrinsic factor, which helps to bind vitamin B12. Vitamin B12 then, in turn, is absorbed in the terminal ileum. Patients who have Crohn's disease, which affects the terminal ileum, will be short in vitamin B12. They also will be short in vitamins D and K. A, D, E, and K are the fat-soluble vitamins. And if you notice, those are absorbed in the jejunum and ileum. In a patient who is very thin and may be suffering from malnourishment or even starvation, they won't have enough of A, D, E, and K because they won't have enough fat intake or even body fat to absorb and to hold these various minerals and vitamins. Also note that you have iron, which is absorbed from the stomach because of the acid environment. Bile salts are in turn absorbed in the ileum. The jejunum is also where amino acids and di and tripeptides are absorbed. This is a very good image, but from bariatric surgery, we've learned the importance of this. This image shows the ones that you probably should be most familiar with. This slide is telling us the same information in a patient who's had another type of gastric bypass. Here, the jejunum is attached to the distal esophagus, and the duodenum is sewn into the proximal jejunum. But here we can see in a linear fashion where the different vitamins and minerals are being absorbed. Again, Tony doesn't have any intestines, so we have to give all of this to him intravenously. But in a normal, healthy adult, supplementation with a daily vitamin usually isn't necessary. So if you take a daily vitamin or you ask your patient to purchase vitamins, have them buy the cheapest one, because most of the time they'll just end up with expensive urine. Most nutritional deficiencies, including vitamins, minerals, sugars, fats, and proteins, can be treated with oral supplementation. But we can't cure them if we can't diagnose them. And it's easier to diagnose if you take a good history and physical exam and look at old operation reports from the surgeons who've operated on the patients in the past to find out what nutritional deficiencies they're suffering from. Some of these nutritional deficiencies, of course, will show up in a blood test. For example, microcytic anemia in somebody who's iron deficient, or megaloblastic anemia in an alcoholic who is not able to absorb folic acid or vitamin B12. You can supplement the patient intravenously or with an oral supplement. There seems to be a new fad going around of women who believe that they need vitamin B12 injections. They're wasting their money, and I believe it's unethical to be giving them vitamin B12 injections if they don't need it, based on blood test, based on history and physical exam, and based on previous operations. If they truly are not absorbing vitamin B12, you can ask for that serum blood test and find out. The most common deficiencies you know about: protein deficiencies, mostly in patients that you'll see who have cirrhosis or patients who have kidney disease. Iron, causing a microcytic anemia. Folic acid, this can be dangerous in a woman who's pregnant, which can lead to a neural tube defect in the baby. Vitamin B12 in patients with Crohn's disease or gastric bypass. And thiamine, vitamin B1. These are the most current ones that you'll see in America and need to address. Remember, Tony has no intestines. We're giving him total parenteral nutrition, and we need to make sure that his protein needs and his vitamin minerals are up to date and current based on his BMR. Here's a review article of vitamin deficiencies after gastric bypass surgery. You don't need to memorize the article. It's just here for your own edification. I won't test you from its content. Some patients after gastric bypass surgery develop a peripheral neuropathy, numbness and tingling in their hands and feet. This can be from a loss of thiamine, vitamin B1, and vitamin B12. Rapid weight loss can also lead to gallstones. You'll often see patients who are on total parenteral nutrition who haven't eaten in a while, who lose weight and then develop gallstones. It can be a real problem. Now take the knowledge that you've gained so far and let's look at a cup of brown rice versus 1 cup of white rice. These are considered standard servings. Caloric intake shows that brown rice actually has just a little bit more calories than a cup of white rice. But the protein is just a little higher in brown rice, but the fat content is almost 5 times more in a cup of brown rice. So if you're trying to watch your diet, you might want to not eat brown rice, thinking that you're getting a lot of fiber. The dietary fiber in brown rice can't be absorbed because it's usually cellulose or cellulose-based. However, white rice only has 0.74 grams of dietary fiber in 1 cup versus 3 grams in brown rice. So there's a lot more fiber in the brown rice than white rice, and it can't be absorbed. But the fat can. So brown rice actually has a little bit more fat than white rice. White rice has more thiamine in it because it's actually added to it, and also has about the same amount of vitamins B2, B3, and almost 40 times more folic acid. So take a look at this chart, and what you're learning about dietary habits, you can look at this and figure up calories from brown rice obtained from protein, carbohydrates, and fat, and see if they add up. Go ahead and do the math. Remember, protein, 4 kcals per gram, carbohydrates, 3.4 kcals per gram, and fat, 9 kcals per gram. So we're back at the scheme. Failure to thrive can result in adequate caloric intake or inadequate caloric intake. What if our patient has the right amount of calories? Let's say Tony has the right amount of calories, but now he's starving. In fact, how do we define starvation? In most of your hospital patients, you're going to define starvation as no glycogen reserves, no fat reserves, and burning protein and losing muscle mass. In fact, starvation usually is a negative nitrogen balance. A patient who is eating a normal or even supranormal amount of calories but continues to lose weight is suffering from malabsorption, from something like Crohn's disease or celiac sprue, or perhaps even short bowel syndrome from surgery where they've had a lot of their intestines removed. Maybe they have cancer or lymphoma and they're in a hypermetabolic state. The scheme isn't perfect here because neoplasm and hypermetabolism sort of go hand in hand. So what can cause malabsorption and cause our patient to starve? We just mentioned a couple. Crohn's disease, which affects the terminal ileum, short bowel syndrome from surgery or intestinal volvulus, or celiac sprue, or perhaps bariatric surgery. There are several reasons that a patient may not be absorbing the potential of all of his nutrients. Even certain medications now, which can be given as a tablet form, will help interfere and block absorption of fats. Do you remember the name of that drug? Because it's available now for clinical use. What if we're giving our patient adequate caloric intake, but they're in the hospital and they're sick? What if, for example, Tony's in the hospital, we're calculating his TPN based on his basal metabolic rate, but he's lying in bed, he's on a ventilator, but he has pneumonia, or he's just had a major operation, or perhaps he likes to exercise. These can all be hypermetabolic processes, and we have to take those into account. We'll talk about figuring out METs in just a minute. Here's another example of failure to thrive caused by cancer. A patient can actually have an adequate caloric intake based on their weight, height, age, and activity level and still be losing weight. Is the patient starving or are they malnourished? Or both? Malnourished means they're not getting adequate nutrients, but we just said that they did with an adequate caloric intake. Sure, but if they're hypermetabolic and they have a negative nitrogen balance, it's possible that they could be starving and have ketones in their urine or be burning muscle mass and losing proteins. Cancer is hypermetabolic, and patients with systemic carcinomatosis or lung cancer, colon cancer, or lymphoma or leukemia can have adequate caloric intakes but still be losing weight. At least that's adequate caloric intake based on a BMR. But based on the total cancer load, it's inadequate caloric intake. There have been some studies that show giving a patient total parenteral nutrition, TPN, actually can cause cancer to grow. So in a patient who has metastatic disease, such as ovarian cancer, the use of TPN is relatively contraindicated. Metabolic stress plays a role in surgical patients as well as patients who are just simply sick. A patient who is lying in bed on a ventilator who has pneumonia or is in diabetic ketoacidosis or who's a victim of trauma, a gunshot wound or a car wreck or a knifing or a severe burn, all of these add to the metabolic stress over and above the basal metabolic rate. The basal metabolic rate was approximated using the 25 kcal per kilogram per day, but your burn patients might actually need 35 or even 40 kcals per kilogram per day of nutrients. How are we going to deliver this amount of calories to such a sick patient? Most of the time we try to do it enterally. We try to do it and use the GI tract. Giving nutrients to the GI tract allows the gut mucosa to stay intact. If we don't feed the gut, it's just like muscle tissue. It withers away and becomes sick and atrophied. But if we use the intestine, the villi in the mucosa, and the overlying absorptive layer of the intestine will stay intact. But if we give it wrong or too much, there's complications to everything that we do. These burn patients, I would estimate their caloric stress to be at the 35 to 40 kcals per kilogram per day. The patient in the photograph in the left lower aspect of this image, with the knife sticking near the right lower quadrant of his abdomen, is going to have an operation, and after surgery he'll need to have more calories than just the 25 kcals per kilogram per day, and we probably can't feed him because his intestine is probably damaged and will need repaired. So the basal metabolic rate is just the start. Then we have to make a guess on how sick our patient is. But is it always just a guess? Can we get better? Is there more science behind this? There is. But first we have to define the levels of activity: low, moderate, and strenuous activity. We all can take a look at this list and see just about where we are. This will all affect our caloric intake. On the right, we have a picture of Atlas holding up the world. If you remember anatomically, Atlas is also the first cervical vertebra who holds up the head. So if you have strenuous physical activity, meaning 60 minutes, 4 to 5 days a week, and there are a lot of construction workers who have a lot more than just strenuous activity, these guys can probably eat 3,000 calories a day and never gain a pound. I always thought it was interesting that the fact muscle cells will use more calories than fat cells during the day, setting a higher overall rate of metabolism. This, of course, goes back to the physiology of the fat cell, and you had some of that as first-year students. Basically, exercise burns more calories and will allow you to go into a negative nitrogen balance, assuming that you are not taking in adequate protein. You don't want to exercise and go into starvation mode. You only want to burn amino acids and proteins if you are in starvation mode. We need to prevent that when we exercise. With this knowledge, you can help explain to your patients what they actually should be doing when they exercise. Calories in should be less than calories out, but that doesn't always mean they should be starving. On some of the treadmills and exercise machines, you actually see this number called a metabolic equivalent, or a MET. I know that on several treadmills made by True, it does show the metabolic equivalents. A metabolic equivalent is 1 kcal per kilogram per hour. So if you're walking on a treadmill and you're at 3.5 or 4 METs, it means that basically you're burning 4 times your basal metabolic equivalent. Or, in summary, 1 kcal per kilogram per hour times 4. That's pretty hefty. Let's take a look at some other metabolic equivalents. Note that sleeping is a 0.9. Watching television is 1.0, meaning that you're not really burning any calories. Writing, typing at a desk, 1.8. Walking up to 3 miles an hour is about 3.3. And of course, jumping rope is 10.0, 10 METs an hour. That's pretty significant. So how does all of this equate to our patient who's sick and lying in bed? What would the metabolic rate be of a patient who has a burn of 40% of his total body surface area? Here we can see it would be 100% above normal, basically 2 times the basal metabolic rate. So when you calculate the caloric intake and needs, you'll need to calculate it at twice normal. For a patient, for example, who has a ruptured appendix, they're probably about 25% above normal. This is how it's important to estimate the caloric intake of your patients. Just because they're in a hospital doesn't mean you're feeding them intravenously. We can use these metabolic equivalents to calculate how to feed patients orally also. At the very bottom, I've given you a link to exercise intensities. Take a look and see what you think. So now let's introduce some more science. How can we actually figure out if our patient has the adequate calories that they need? How do we know if our Harris-Benedict equation or our guess at their activity level has been appropriate? We can use something called a metabolic cart. These are photos of athletes using a metabolic cart to measure the expired CO2. If we are able to calculate the amount of oxygen which is inhaled and the CO2 which is expired, and we know the chemical formula for the oxidation of glucose, we can figure up how much and what fuel they're burning. We can tell if we're under or overfeeding them. How can we use this equation to determine how much to feed them? Well, let's take a look at some of the numbers. If our patient is in a hospital and we need to assess them and they're unable to walk, we can do one of these tests. The metabolic cart can actually be used over the patient's head and face and neck, and we can still measure the amount of CO2 produced. It's still not an issue. If a patient's on a ventilator, it's actually even easier. We just hook it up to their endotracheal tube. The metabolic cart helps us to measure what's called the respiratory quotient. The respiratory quotient is defined as the CO2 eliminated divided by the oxygen consumed. And most importantly, you'll need to memorize these 4 numbers. The respiratory quotient for a patient who is burning purely carbohydrates as a fuel is 1. A patient who is burning proteins is about 0.8, and a patient who's burning solely fats is 0.7. If a patient is hypocaloric and they're not getting enough nutrients and they're in a negative nitrogen balance, we'll know because the metabolic quotient is less than 1 at 0.66. If they're eucaloric but they're still ketotic, it'll be at 0.7. For example, this could actually be a diabetic who is hypermetabolic with hyperglycemia but not producing insulin, and the sugar is not being pushed into the cell and being used. Hence, they could be in ketoacidosis but be eucaloric. If we know these numbers, carbohydrates at 1, proteins at 0.8, fats at 0.7, we can measure which substrate this patient is using and or which substrate we need to provide the patient. It's all pretty complicated, and you'll learn more about this in residency. For now, just understand that nutrition can actually be a science. What about this? What if our patient now has an inadequate caloric intake and they're in a negative nitrogen balance? Are they starving, or are they just malnourished, or are they both? Well, what if we have an inadequate caloric intake, but the patient is gaining weight with our feeding? What does that mean? What if we're feeding them inadequately, and of course they would be losing weight, but they've had no weight gain with the feeding? Or perhaps they're just not eating because they're not hungry. Are they actually in starvation mode, or just malnourished, or both? How can we have a patient who is gaining weight with feedings if we're giving them inadequate calories? In box G here, we see weight gain with feeding. The most common cause of this is fluid weight. We're giving the patient too much intravenous fluid and not enough calories. In box H, where they have no weight gain with feeding and we're giving them inadequate caloric intake, we need to increase the calories. If a patient simply isn't eating and they're not taking in enough calories, they can go into negative nitrogen balance and begin starvation mode. You knew that your organic chemistry was going to come back to haunt you. Dr. Geldahl had invented a method of giving an estimation of protein contents in foods. It's not totally accurate, but it's still used. That in combination with measuring the amount of nitrogen in your urine. A patient who's in a hospital and we need to figure out whether we're giving them adequate protein, we'll sometimes assess 24-hour urine-urea nitrogen contents. We can measure the daily protein output and compare it. If the patient's in a positive balance, the amount of protein which is excreted will actually increase. Note that the way that I say this, if a patient is in need of keeping his nitrogen to build protein, you'll see less nitrogen in the urine. As they become a more positive balance, you'll see more and more nitrogen in the urine, which is excreted as ammonia, hence the odor of your urine. So just exactly how do we feed somebody who can't eat, but they still have all their parts? Unlike Tony, who lost all of his intestines, we now have patients who have all of their intestines. Maybe they're just on a ventilator and have pneumonia. We can calculate their BMR, give them a stress factor of, say, 20%, and now we need to feed them enterally via the intestine. We can do that with a gastrostomy tube, or we can do it via a nasogastric tube. Photos here show a nasogastric tube and a gastrostomy tube. If the tube is placed directly into the small intestine, that's called a jejunostomy tube. If it's put from the nose down into the stomach and threaded down into the small bowel, that's called a nasojejunal tube. These are ways which we can give patients enteral feedings through the gut. The calculations are still the same. So once we've calculated the patient's BMR and we know the basal needs, and we've calculated the amount of stress the patient is under, we can pick a formula. Most of the formulas, like Ensure, which is advertised on television, and Glucerna, are about 1 kcal per cc. You'll need to memorize that too. Most of these formulas, not all, are about 1 kcal per cc, and they're given enterally through a feeding tube. The Ensure commercials always make me laugh because it shows two elderly people out rowing a boat, and they're supplementing their diet every day by drinking Ensure Plus. This is not what these chemicals were intended for. Some of these taste horrible and are indicated for patients who've had a stroke, who can't swallow, patients who are in a hospital, who can't feed themselves or eat. They're given as what's called tube feedings. A patient who's a burn patient, for example, probably needs the formula that provides him 2 kcals per cc. The diabetic formula, such as Glucerna, will be higher in fats and proteins and less in glucose, because a patient who's diabetic should have less glucose. Pedialyte, Pediasure, all of these are infant formulas, and the calculations are still the same. Here's an example of some of the commercially available enteral formulas. Just like Ensure, they provide calories enterally and they don't taste very good. But there are special formulas for patients who have burn injuries or liver failure or kidney failure. For example, a patient who has kidney failure will have less protein because too much protein can be harmful to the kidneys. A hepatic failure will also have less protein. Too many proteins cannot be broken down in the liver, and the patient will go into hepatic encephalopathy if they're given too many proteins. Elemental diets are actually pre-digested and can be given directly into the small intestine. The most common elemental diet when I was in residency was called Vivanex. They still make Vivanex, but there are several other enteral formulas. These will be available to you as a clinician and as a physician, and most of these should actually be written with the help of your registered dietitian. With the knowledge that you have of nutrition now, you're able to calculate the basal metabolic rate, the stress needs, the water and fluid needs. Now take a look at this Ensure high protein advertisement. Can you break apart these advertisements and see if they're legit? Can you actually look at a label of Ensure and calculate the calories and see if it's accurate? Take a look at this #1 doctor recommended supplement. Watch the video and see what you think. It's gotten so out of hand that doctors are now doing a feeding tube diet. On the left, we see an individual who's lost a great deal of weight. Most likely, her doctor put a feeding tube down, and I've given you the link to the website. This is becoming more and more common for brides-to-be that want to fit into their wedding dresses. Drop a feeding tube, go on an Ensure diet, go into hypocaloric restrictions, and before you know it, they've lost weight. So the question is, was the weight loss healthy? Was it supervised? Was it done slowly? Were they in ketosis? Were they starving or were they malnourished or both? On the right, we see a patient who has a gastrostomy tube in place. Percutaneous, endoscopically placed gastrostomy tube. You'll see these in your hospitalized patients. It's in that patient on the right that these supplements are recommended. Even over-the-counter supplements, such as Slim Fast, fit into this category. Here's a good one. You see this on television, a 5-hour energy drink. But if you see what's actually in it, we have niacin, vitamin B6, folic acid, vitamin B12, sodium, and of course, caffeine. But what we need to know is there actually any energy in this drink? The answer, of course, is no. There's nothing here that provides useful energy because our energy needs to come from either protein, fats, or carbohydrates. So these cost about $1 a bottle, which I think you'd be better saving your money. You could actually take a shot of coffee or 2 cups of coffee and get as much, if not more, energy than this 5-hour energy drink. But they play on stupid people's ignorance. There is no energy in this, just vitamins, and they can't be used as an energy source. So now that we've come this far, we've been able to figure out caloric needs. We need to make sure that our patient is in a positive nitrogen balance and their nutrition is in positive balance. How do we do this? Well, we know that measuring body weight or daily weights is just a guess. It's just an indicator. Your patient's body weight can fluctuate up or down based on fluid balance, especially in someone who has intravenous fluids. Serum albumin is notoriously inaccurate and should not be relied upon as a measure of nutritional success. You will see this used in hospitals and it's used wrong. Albumin, in my experience, should be used mostly to calculate your true serum calcium concentrations and other medications. You can use serum albumin as a guide to measure of oncotic pressure, but it's not a good measure of nutrition or success in nutrition therapy. Skin calipers that you have done at the gym are inaccurate. The preferred method to measure success in helping someone who is nutritionally repleted is to measure their serum prealbumin, transferrin, or retinol binding proteins. These are readily available. All hospitals offer them, and they're relatively inexpensive. You could also do a metabolic cart study, but they're usually pretty expensive, and not all hospitals have them. You should measure daily serum electrolytes, a BUN, and a creatinine on any patient who has total parenteral nutrition. And you should measure liver enzymes and a liver panel about once a week to make sure you're not overfeeding your patient with too many lipids and causing a fatty liver. The take-home message is don't use albumin and don't rely on a daily weight to give you an accurate indicator of the nutritional assessment of your patient. So I saved the hardest for last. If you want to go and understand the biochemistry of all of this, I've given you a link to an interactive site which goes through gluconeogenesis. A patient will enter gluconeogenesis once their glucose stores and their glycogen stores have been depleted. Once they go into starvation, they actually will begin making glucose from protein breakdown. Lactic acid is broken down in the Cori cycle, and eventually your patient who doesn't eat for up to 10 days shows up in the emergency room with ketones in their urine. Assuming they're not diabetic and they're not in ketoacidosis, ketones in the urine means you need to hydrate your patient and probably feed them and give them some dextrose. And of course, finally, I've given you a link to a Scientific American article which talks about all of this. I hope you've enjoyed the presentation. Remember, I will include questions on your exam, not only from the presentation, but from Chapter 22 from the American College of Surgeons Nutritional Support chapter. If you've made it through it this far, you have enough information to walk onto the floor as a third-year medical student and begin to fine-tune this information. How to write your TPN orders, how much minerals to give, how much vitamins, when they should be given, when they shouldn't be given. There's a lot of information here, but as a second-year student, I've kept it down to just what you need to know. So, have we talked about failure to thrive? Yes. Have we talked about metabolic stress and starvation? Yes. Have we defined them? Starvation is difficult to define, and malnutrition is difficult to define. In America, we don't usually see kwashiorkor or marasmus, but we will see hepatic encephalopathy and kidney failure, and you need to know how to address those. Good luck. I hope you've enjoyed the presentation. If you have any questions, please feel free to email me.